Ladies and gentlemen, welcome back to another fabulous episode of the Healthcare Trailblazers podcast. Here on this wonderful morning with none other than Gary Rothenberg. Gary is the medical director of a company called Podimetrics. And Podimetrics is interesting. The reason why I want to talk to you today, because you make some really cool, innovative devices, specifically around a mat. Let's jump right in. Tell me about the mat.
Yeah. Appreciate you having me on the show today, Mendel. Thanks. I am a podiatrist. I'm the medical director for Podimetrics, and I've been practicing about 25 years now. And there is a huge problem with diabetes and amputations. We're especially noting that underrepresented minorities are especially vulnerable and experiencing complications associated with diabetes in terms of infections, amputations at very alarming rates. So at Podimetrics, we actually have technology where we can detect and hopefully prevent diabetic foot ulcers, which are part of the cascade and lead to that unfortunate end result of amputation. So it's based on temperature monitoring of feet. And as we like to say, the foot heats up before it breaks down. So some of the studies that I've been involved with, very fortunate with the company, again, we can detect 97% of impending complications at a lead time of about 35 days. So 5 weeks in advance of a foot complication, we know that a problem is developing. And it's not necessarily what we do with that. It's not necessarily that data, but what we do with it. And so at Podimetrics, we have nurses who that prompts a phone call. And so they'll call the patient and say, hey, Mr. Jones, how's your day? First of all, we start off with that and then figure out what's going on that might be causing some inflammation in the feet. Has the patient walked more than usual, gone to their grandkids' baseball game and done a little extra walking, or breaking in a new pair of shoes that they thought were comfortable, but maybe aren't so comfortable and are causing a problem. So it's what do we do with that information? So we kind of care support these patients and hopefully put them on a path that's more towards resolution of that potential problem instead of development of further complications.
Yeah. You know, I spoke to you about this offline because I really like seeing devices that are trying to be, integrated into a patient's possible life, not workflow, but like day flow. You know what I mean? Like into your schedule, something that fits into your life already that can then start capturing data in a positive way. Obviously that's what they did with the idea of smartwatches, right? The idea was, hey, people wear watches all the time. We don't have to start coming out with pendants that people are not going to. We could just put this in a watch, right? And so, talk me through kind of the origins of the mat, and just the design, like the actual product.
Yeah. No, I appreciate you saying that, and we believe that too. That's why we have innovated kind of a simple solution that literally takes 20 seconds, and you can do it while you're doing something else, like literally brushing your teeth, because it is a mat. It's called the SmartMat, and it is the size of a regular bath mat. You can put it in front of your sink, take 20 seconds and brush your teeth, and you get your foot scan done at the same time. Historically, this technology is an innovation of some very sound science that was done. Actually, temperature monitoring goes back to the early 1970s, but there were some innovations in management or research in the early 2000s, which showed that if you add temperature monitoring to feet, a normal prevention strategy of feet, you can reduce diabetic foot ulcers and amputations by 72%. But unfortunately, that form factor was not patient friendly. The patient had to use their essentially a gooseneck thermometer, do the readings themselves, do the math, look for this temperature asymmetry, and then also intervene on their own. And it was just too much of a burden, this very complex patient already with diabetes, to then have to do all of that. So yes, we innovated. We didn't invent temperature monitoring, but we did innovate it to the form factor that you step on this mat, It takes 20 seconds to develop essentially a heat map or a thermogram of the foot. And then actually it doesn't require Wi-Fi. There's no hub. The mat actually connects to the local cell tower closest to the patient's home or wherever they are. And then through cellular technology, the scan is transmitted to Podimetrics headquarters, which is in Boston. But we have over 50 nurses around the country that are monitoring patients for temperature asymmetry and hotspots. So yes, very simple solution that you can easily make a part of your daily habit, because you can associate it, as I mentioned, with brushing your teeth or taking your morning meds or doing whatever you need to.
Yeah.
So, yeah.
And so who do you, I guess from both directions, who do you sell to? And then on the flip side, like what is the patient's relationship with you guys?
Yeah. So much of our research was done in the VA system. That's where the original kind of trials improving the efficacy was done in the veterans population. And so they became an early adopter because of the very sound science that came out. We also are working with health plans that assume risk, understanding that prevention, especially in the diabetic foot ulcer space, is actually the right thing to do, of course, for our patients, but it's also much more cost effective than performing amputations among these high-risk patients. So if I think about my career in treating patients with diabetes, and I always say nobody comes into my clinic with diabetes alone. They all have other comorbidities, especially coronary disease, kidney disease, right? And the huge burden of mental health that we're seeing associated with diabetes these days. So that's our typical patient is a high-risk patient that is costing health plans a lot of money, because the diabetic foot is really just a marker for other comorbidities in this patient population. Like if you go to a dialysis center and you peel back the sheets as patients are sitting on the dialysis machine, you will find diabetic foot ulcers, right? If you go into a hospital ward and you see the patients who are admitted for diabetic foot ulcers, they also have coronary disease and kidney disease. So there's this interrelationship between so many comorbidities. That's our target patient. We're still at the point where we're doing secondary prevention. The classic patient who is a good candidate for a SmartMat is somebody who's already had a diabetic foot ulcer or a partial foot amputation. We're trying to prevent the subsequent ones because recidivism rates are so high. Once you've demonstrated risk, there's no going back. You unfortunately are going to be at high risk for developing further complications.
Yeah. So who's calling the patient from the patient's perspective? Is it?
Yeah.
Yeah.
So we employ, as I mentioned, over 50 nurses. The Podimetrics team, our clinical and non-clinical folks, they will call once the SmartMat has been prescribed for a patient. Our team calls, educates them on the significance and the importance of this. We do global foot education. It's not just about the mat, but it's about maintaining good, healthy foot habits, wearing appropriate shoes and inserts, checking feet daily. So our nurses will reinforce all of those habits. And then the nurses, it's kind of a no news is good news program. If you don't hear from us, your feet aren't heating up. But we do touch base with every patient at least every 4 weeks, because we do want to reinforce those good foot habits. And we want to make sure that they know we're receiving their scans, and attaboy, you're not.
What if you're not? What if you're not receiving their scans?
So we know if we are, we aren't. And actually we have a subsequent call type that if a patient doesn't step on the mat for 4 consecutive days, that prompts a phone call as well. We assume this is an easy habit to do. There must be something in your life that's happened. And the things that we hear when the nurses will call for what we call a re-engagement call after 4 days, it could be something as simple as, hey, I'm in Hawaii on vacation. And we're like, good, have a great time. Be careful with your feet. Or it could be that they're in the hospital, unfortunately, is a more common experience. So yes, we do that. But in the case that there is inflammation 2 consecutive days above a threshold that's established per protocol, the nurse is calling and doing essentially a telephonic history and physical. If there is something clinically relevant and important and a new finding that the prescriber, typically the podiatrist, is unaware of, then we escalate those findings to the provider so that they can be aware of those and triage and potentially see the patients for an upcoming appointment, especially if they're not already scheduled.
Mm-hmm. Interesting. How common is it to have an issue with other family members or other people standing on the mat and messing up the readings.
Yeah, so the most common thing that we get is a CAT scan. No, we know when somebody else steps on the mat or when there's a pet or something like that, because actually it's a single patient mat in the home. And so the mat has to develop a template. It gets to know the individual patient because we're looking for deviations from their usual baseline. So if somebody else was to step on it or an animal was to step on it, actually immediately the software would identify that as an aberrant.
So it's different than, say, a scale, like a remote patient monitoring scale, because the scale it's just a scale. You either weigh more or less. There's not really a unique kind of imprint.
Correct.
Okay.
We develop a unique template. Takes about almost a week, usually the first 5 scans, for the software to identify the appropriate outline, because again, many of these patients have abnormal shaped feet. Maybe, unfortunately, they've already had a big toe removed. So it takes about 5 scans for the software to learn the patient's baseline so that we can then, again, look for variations from that usual baseline.
Got it. Yeah, that's really cool. And it doesn't currently work as a scale as well, right? It's just
It does not. Future generations, we do have future iterations. And so our thought process as we move forward is, okay, we have 20 seconds with a patient where they're stepping on a mat. What other clinical information can we gather? And then on the other side, when our nurses, we have very high engagement rates. Surprisingly, even among Medicaid patients, dual eligible MA patients, we have very high engagement rates. And I hypothesize that this is because we are a preventive strategy and patients have the lived experience. Healing a diabetic foot ulcer can literally take 6 months, 9 months. And people are taken out of life. They have to stop walking, or they look down in the shower every morning and they see toes missing. So they have lived experience. So when our nurses, when that number, Podimetrics, pops up on your caller ID, patients pick up the phone. So you're asking about the next gen. We also are very curious, because we have such high engagement rates, what other useful information can we gather while our patients are on the phone with the Podimetrics nurses? And that seems to be trending in the direction of social determinants of health, healthcare disparities, because again, the patients, they're complex. They're living with diabetes. They know a nurse is on the other line and they just want to share and they feel comfortable acknowledging that life is hard or that they're having trouble or other issues. So yeah, next gen seems to be what else can we gather clinically, but also how can we help support the patients in terms of SDOH issues and mental health disease.
Yeah. So let's talk about that patient engagement rate for a little bit. And what's your bragging rights on like, do you brag on patients? What's your patient number, whatever?
Yeah. So our engagement rates for a Medicaid population is generally over 70% of the patients are engaged in a meaningful way at a year. In a Medicare Advantage plan, we have a plan that we work with in the Northeast. MA plan patients are stepping on the mat at 85% of clinically meaningful ways. So when we talk to new health plans about engagement, they're really surprised. They're really shocked at those high engagement rates. But again, I believe it's all about how the provider presents that to the patient, as well as the support that we give. But again, remembering that they have the lived experience of a complication already, and they just don't want to experience that again. Yeah.
So, and that's really what I want to kind of get into is the actual conversation. So just kind of recapping what you said. So a mat will get shipped out to a patient, and then one of your nurses will go ahead and call the patient once they see it's been delivered, and they'll kind of orient the patient about the mat. And then they're monitoring it. If there's ever any issues, then they call. If there aren't any issues, they call once every 4 weeks. And if they're not seeing any readings, then they're calling as well, right?
You got it. You got it.
So, but I want to try to get into your approach on the actual engagement with the patient, because and I speak about this with so many healthcare leaders about, at the end of the day, you can have a better device, you can have better technology, you can have a more colorful brochure, you can have but if you cannot get the patient meaningfully into the conversation about their health and trying to better their health, you will not win, especially when it comes to risk and value-based care, right? And so you seem to be winning at that actual engagement. What is kind of your approach or your thought process or philosophies that you think are creating those levels of success?
Yeah, I appreciate you asking that. And it's not easy. Let me just acknowledge that. Again, because the patients are living with complex diabetes and especially the mental health that we see. One of the things that we have learned and that we have instituted is what we call primary nurse model. That means geographically, patients on the West Coast are followed by, nurse Beth is assigned to this cohort of patients. So Beth gets to know all of the patients and the patients get to know her so that theoretically, she gets to ask about the grandson's baseball game that the patient went to. So I think that level of engagement and connection with the patient is really important. So I get the privilege of kind of working with all of our nurses, and we talk a lot about diabetes distress these days, right? Acknowledging, and that's so big in the news, that just acknowledging that living with diabetes is hard, and especially in this cohort of patients that we work with who've already had complications, kind of meeting them in the middle, like figuring out, hey, if you're not able to step on that mat, what is going on in your life? Because it is simple. It's 20 seconds a day. So I would say acknowledging diabetes distress and the mental health component, and then trying to get to know the patient themselves and personalize that care. That seems to be a recipe for success for our company.
Yeah. Fascinating. And how long have you been with Podimetrics?
Yeah, so I was introduced to the company about 10 years ago when I was at the Miami VA, and I was running a residency program in podiatric medicine and surgery, and we were one of the original sites for the SmartMat feasibility and efficacy study. And so I became a believer. I started drinking the Kool-Aid because I saw what we could do with prevention. And so subsequently, we published several articles, and the company asked me, would I be willing to do some consulting, which I was happy to because of the mission, because of the sound science. And then 2 years ago, I actually came on full-time as the director of medical affairs. So yeah, it's been a great journey, and it's such a strong mission-driven company around ending avoidable amputations for people living with diabetes. That's what we try and do.
Yeah. What have been kind of some of the ups and downs over those 10 years that you've, even as an outside observer, so to speak, observed? Yeah. What have been some points of progress?
Sure. So again, the company, I don't know at what point you stop calling a company a startup, right? Yeah. It's been around about 13 years. We now have 206 employees. Wow. So there, again, the biggest team includes our clinical, non-clinical team who are patient-facing. But of course, there's a team that has to support that in terms of software and shipping, and everybody's role is super important. But what I see the common denominator is that people really appreciate the mission. A lot of us are connected with diabetes personally. I actually have a son with type 1 diabetes who's a student athlete in college and doing really well. But I think when you combine personal and professional, oftentimes you get passion. And so I think that's really, really important. So those are definitely some of the highs that we've seen. The challenge is, of course, getting payers, is getting people to understand that this is a complex patient, that amputations are preventable. And then some of the other challenges, of course, are around racial inequities in healthcare. Even within our own programs, we've seen prescribers don't always utilize it for rural patients or for underrepresented minority patients. And
Why
so
not?
you would, great question. You would think a rural patient who's farther away from the clinic, this is a perfect technology to tether and connect these patients to the clinic. It's probably some inherent bias by prescribers, right? That they are out of sight, out of mind, that those patients that tend to be in front of us in the clinic, tend to get more treatment. So that's...
Can it be that? So I live in a relatively rural area in Pennsylvania, and we do a remote patient monitoring program, typically with also cellular devices, but scales of blood pressure cuffs. And we find that there are a bunch of areas that just the actual cell service is so spotty that the device becomes almost unusable. Do you have any issues with coverage?
Surprisingly, we do not. And we do get cellular, there are occasional issues. So we have patients in 49 states. The only state we don't have is Alaska right now. But we're actually monitoring patients in Puerto Rico and Guam through the Veterans Affairs healthcare system. We don't have problems. We can give patients cellular extenders if that's an issue, but we have patients in rural Wyoming.
You have any Starlink stuff or no?
Right. Going in that direction for sure, right? But we know that we have patients in rural Montana that we're monitoring, and it's not an issue. So, yeah, I think it's around healthcare inequities. It's unfortunate, but we see these patients with Medicaid or patients who are, again, underrepresented minorities that just are not getting the same leveled playing field in terms of incorporation of technology into their daily lives. I'm sure it's reimbursement as well, right? It's around payment.
What about actual adherence and to, and compliance, so to speak, and actual taking, those readings every day? Do you see any kind of demographic differences? Is there like socioeconomic angle to it? Do you see any differences, or is everyone just compliant or non-compliant equally?
Yeah. So I love that you asked me this because it's a particular passion and interest of mine. I truly believe that patient adherence and engagement is not a patient problem. It's a provider problem. And I believe that patients are provider pleasers. They want to do what we ask them to do. They just need to understand why. So I'm really glad you brought this up too, because Podimetrics is just embarked. Actually, we're midway through a pilot trial at Montefiore Medical Center in the Bronx. And the researchers there actually have some NIH funding, and they came to us, which is a wonderful position to be in. They had reviewed all the tech in the diabetic foot ulcer prevention space. They landed on the SmartMat. And in the words of the researchers at Montefiore, they want to use our technology to tether patients to the clinic. So this is in the Bronx. It's all Black-brown patients. And we've enrolled all 20 patients in this pilot study. And actually the adherence is over 6 days per week. And the reason for that is the primary investigator podiatrist there, her name is Dr. Denise Levy. And I asked her the question. I said, Denise, why are your patients stepping on that mat higher than the national average? She said, because they're scared of me. Because I told them to. And you have to understand, she's about as big as a minute.
I'm sorry.
No, she's a wonderful physician, takes time with her patients, and she told them to. And so and it's more than that. It's around the conversation. Mr. Jones, remember how it took 9 months to heal your foot wound? Remember how you look down in the shower and there's 5 toes missing on your right foot? Like, I don't want that to happen to you again. So just step on this mat for 20 seconds a day. And that technology can help me help you to avoid that potential problem. So my mantra is, the most valued relationship in healthcare, in my opinion, is trust between the provider and the patient. And data and technology should serve to augment that trust relationship. And that's what's happening at Montefiore with Dr. Levy and her patients in the Bronx.
Yeah, that's really funny. I did not see that coming. Are you going to be, so now that pilot's done, are you going to be rolling out to a bunch more patients?
Well, that's our goal. We're actually in the middle of it. It's a 6-month pilot. We've enrolled all 20 patients, and then they actually are going to write it up, and they hope to use it for future studies, a bigger study. And then obviously we hope to use it to show, hey, Black-brown populations, which you typically, I say which are typically deemed non-adherent, non-compliant. That's not true. You give them technology, they will use it. And we showed that too. Podimetrics recently did a study of 1,000 Medicaid patients, and the Medicaid population, they want to use technology. They're not intimidated or scared by it. In fact, the survey study showed that only about 1 in 5 patients are already with Medicaid or using current remote patient monitoring, mostly continuous glucose monitors, as you may have mentioned, which I think is great because that has an overarching benefit to diabetes management, and that's awesome. But Medicaid patients, underrepresented minority patients, they want to use technology. They're not intimidated by it. They do think it would help overall healthcare and promote prevention instead of complication management, for sure.
Yeah. Okay. I totally remembered what I wanted to ask you
Good.
about. So, one of the areas that we're really touching on that fascinate me is the use of social psychology and persuasion techniques in healthcare, which I think there is a complete and utter lack of comparative to, say, the sales industry or even like the fast food industry. Like, you've got these huge industries that make a lot of money. What they do is they employ people whose sole jobs are to figure out how to psychologically trap people to their product, right? And you've got good versions of that for society. You've got bad versions of that for society. But I feel like we don't leverage that in healthcare at all. And, there's this guy, you may remember, you may know, like Dilbert comics.
Yeah.
So the author there, his name's Scott Adams. And his whole lens on life is this, like, persuasion. And I hounded him. I reached out. I wanted to collab with him on this. And he finally got back. He's like, I don't collab with people. It's like, all right, whatever, dude. But I'm super fascinated by the concept of using persuasion techniques in healthcare. And I think this is a great example of it. And I think actually what I wanted to use it for exactly this, not obviously the mat, but other remote patient monitoring devices, but the concept of figuring out the perfect pitch and the perfect way to get patients hooked on using these devices. And obviously small parts of that are like what we talked about, getting it built into their workflow and things like that. So I'm curious if you're doing anything around that, but even more just practically speaking, do you see any kind of patterns as far as, if we could just get the patient to take it for X amount of time, we don't have an issue again. You know what I mean? Like, I'm curious if you're seeing any facts around how to get the patients hooked to taking the readings.
Yeah. So it's, again, my inherent bias that is on the front end. Like, it's all about education. And if your provider tells you to do this, I mean, that's the reality, right? Is that a doctor may prescribe a medication which makes people really sick. Like, they vomit, they throw up, they have an untoward reaction, but you take that medicine because you've been prescribed it, or you try and work through it if it's a minor kind of side effect. So again, I believe that the persuasion that you're talking about comes on the front end, and making something simple like standing on a mat, but explaining to patients why they need to do that, and just, engaging them on the front end, and then our team can take it from there. But what I've noted is the patients that are less engaged, it's because their providers are less engaged, right? It's because they haven't spent the time on the front end to understand what's going on.
Yeah, and why. That's unfortunate, because I think that's actually a growing trend. Like, the concept of having a family doctor that, has known you since you're a kid, or possibly even like gave birth to you, and you really trust, that relationship has been eroded almost completely. And it's much more often to just have kind of a rotational doctor kind of set up at a health system. You come and you more belong to the system than any, one doctor. So that concerns me,
That's right. That's the hospitalist concept, right? Yeah. No, your doctor doesn't come and see you in the hospital anymore. The role of somebody who doesn't know you at all is to review your medical record and treat you and get you out of the hospital and get you back to your primary doctor. I totally agree. Totally agree.
Wow. Well, always a fascinating discussion, Gary. What's give me a what's your goal for 2025?
Yeah. So we want to bend the curve, right? These amputations are occurring at really escalating and alarming numbers, too much. So especially among Native Americans, Black and Brown communities, we are doing our best to try and bend the curve, knowing that amputations are occurring in those communities at 2 to 4 times the rate of Caucasian Americans. So we need to embrace the technology. We love the folks that are early adopters for it. Amputations are preventable in 75% of the cases. We just need to get more mats in homes. And again, I think explaining why they need to do it, because it's the right thing for quality of life for our patients, but it's also cost effective in the long run for health plans. Amputations are really, really expensive. And so we need to be more proactive and preventive for sure.
Incredible. Well, ladies and gentlemen, Gary Rothenberg. Find Gary on LinkedIn. Look at Podimetrics at their website, Podimetrics, what is it?
.com. Podimetrics.com.
Great,
yeah.
Great URL.
Easy.
And Gary, thanks so much for spending time. This is awesome.
Appreciate you having me. Thank you to you and your listeners.